A very warm welcome to today's Journal Club session organized by the Society of Indian Medical Students of Obstetrics and Gynecology. Before we proceed further, it is to inform everyone that the session is being recorded. SIMSOG is India's first student-led organization dedicated to obstetrics and gynecology with the motto of breaking boundaries and building hope. Our topic for the discussion is Menopause, Current Perspectives and Evolving Research. We are delighted to have Dr. Ragini, Secretary General, Indian Menopause Society, here with us today. Dr. Ragini is a distinguished obstetrician-gynecologist and a visionary women's health leader with over 3 decades of experience. Currently the director of OB-GYN and MAS at Cloud9 Hospital, Gurgaon, she has held several prestigious positions, including Vice President Proxy and President-elect NIGF. A pioneer in gynecological endoscopy and aesthetic gynecology, she has many firsts to her name. Dr. Ragini has been instrumental in promoting holistic and preventive healthcare for women. We are delighted to have you here, ma'am. The presenter for today is Sharvaree from GMC Thiruvallur. Over to you, Sharvaree.
Thank you. So my First of all, good evening to everyone. My topic for today's journal presentation is Menopause Impacts Human Brain Structure, Connectivity, Energy Metabolism, and Amyloid-beta Deposition. It's authored by Lisa Mosconi et al., and I took it from Scientific Reports 2021. Starting with, so we already know that menopause is like it's an important transition in every woman's life. Like it's when you go from being in your reproductive age to what you call the senescent stage of your life. We are aware of like the hot flashes and other things which happen, such as brain fog and sleep disturbance. And we also know this is when our menstrual cycle, it stops. So because of which our estrogen levels, it's going to drop. So there are multiple studies regarding menopause as such, but they're mainly from animals or just high-risk population, not like an in general study with normal population also. So what this study is, it plans to map the female brain across this transition, across the menopausal transition. And it also tries to focus on the Alzheimer's disease, and it's trying to explain why Alzheimer's is more common in women than it is in men. So the research question here is, how do brain structure, connectivity, energy metabolism, and amyloid beta deposition change across the stages of the menopausal transition? Another question, the secondary question here is, are these changes because of endocrine aging or simply because the woman is chronologically aging, like she's getting older? Now, methodology. So what they did was, it's a cross-sectional observational study with, it's a small 2-year longitudinal follow-up component is also present. So who are the participants? They took 161 cognitively normal women from the ages of 40 to 65 who are premenopausal, perimenopausal, and postmenopausal. Now they took 30 premenopausal, 57 perimenopausal, and 74 postmenopausal. And the control group here is the men. They age matched the men. Like if the woman was 42 years old, they took another man who was also 42 years old. Another special thing about this study is they took the APOE status, which we know it is a risk factor for Alzheimer's. So, but the thing about this study was it had 47 of APOE carriers, which is much higher than the general population. So the data which was collected. So for the brain structure as such, they took MRI of the gray matter and the white matter volume. They did DTI for fractional anisotropy, which basically tells us the integrity of the white matter. For metabolism and function, they did FDG PET for cerebral glucose metabolism, ASL MRI for cerebral blood flow, and 31 phosphorus MRS for brain ATP production. For pathology, they did PIV PET to check for the amyloid-beta deposition, and cognition, they used the standardized neurophysiological tests. Now, the statistical analysis was done by SPM12. The analysis were adjusted for age, the APOE status, and the modality-specific co-founders. Now, what about the key comparisons? They were between the female groups, between the pre, peri, and post-menopausal groups, as well as between the each group and their male control. Now, the results. Now, the main difference they found here was that the main issue, all the problems which a woman faces during her menopause, they were all in the perimenopause state. The gray matter volume was the lowest in the peri group. The CMR, which is basically glucose metabolism, it declined significantly in the post group. And the amyloid beta deposition, it was higher in the peri and the post compared to the pre and the age matched men. Also, it was much more increased in the APOE carriers. So if you look at the diagram here, the moment the perimenopause stage starts, the fractional anisotropy, which tells the integrity of white matter, it is reducing. White matter volume is also reducing, and cerebral glucose metabolism, it is reducing. The rest of the things, they continue as normal. Now, in post-menopause, what is happening? We already saw that the gray matter volume, as it decreases in the perimenopause stage, it does not continue decreasing in the post-menopause stage. However, this recovery was not seen in men because obviously they don't have a perimenopause stage. Then there's an energetic shift, as in, if you look at the cerebral glucose metabolism, it is drastically decreasing in the perimenopause, but in the post-menopause, it manages to stay constant, as in the body has found another equilibrium state. And the white matter efficiency, which is told by the fractional anisotropy, it is also being compensated. Another main thing is the fractional anisotropy, which they saw, compared to the ones in men, it was higher in women, which means that even though there are lesser white matter tracts, they are more efficient. Coming to the cognition, there was no significant cognitive decline found between the groups. In the post groups, the better memory was linked because of the gray matter volume, where gray matter was more concise, it had better tracts, and there was better global cognition because of higher ATP production. So, what are we interpreting here? The perimenopausal storm with structural and metabolical decline. However, in the post-menopause, there's a reset with adaptation and recovery, which shows that brain, it shows a remarkable plasticity. So it is finding new ways to produce energy, such as increasing its blood flow. There's increase in cerebral blood flow, as well as the fractional anisotropy is also increasing, so that it can maintain function even after estrogen is reduced. Compared to the previous research, the new finding here, the similar finding was it supposed the data on estrogen's role. So because estrogen is less in the perimenopause, there is certain decline. However, the novel finding here is the gray matter volume recovery and the dissociation between glucose metabolism and ATP production. Now, what are the strengths of this journal? It's a multimodal approach, which gives like an all-rounder view because we are checking for structure, we are checking for metabolism, we are also checking for cognitive function. There's age matching between females and males to isolate the menopause effect so that we're not just, we know for sure that the effect is because of menopause and not just because of chronological aging. And the sample size is comparatively large. And there is a longitudinal data in the subset which strengthens its cross-sectional findings. The limitations here would be that we see different women at different stages. We're not seeing just single woman transitioning. And then this cohort generalizability, which said that the study as such, it had mainly white, educated, and self-referred women. So because of which it resulted in a high APOA also. So it's overrepresenting the high-risk group. And we did not measure any hormones here. We did not check for the estrogen levels. So the conclusion here, it is that menopause is significantly and dynamically impacts the human brain. And it is the perimenopausal phase, which is the vulnerable part of a woman's life for initiating Alzheimer's. But the postmenopausal, there is adaptation and the brain recovers and there is no decline in cognition. The future research directions which someone could go is the large-scale longitudinal studies, which you can track a single woman going through the transition, or you could investigate these processes in more ethnic and socioeconomic populations, because this one was mainly, it was highly educated white women. And you could test interventions such as hormone therapy or lifestyle during this window. But the practical applications of this study for clinicians, we get to know that the perimenopausal is the key time for brain health counseling to prevent Alzheimer's. And for the public, we can tell them that there's no such thing as menopause brain. Like a woman, even after she undergoes menopause, she does not lose any cognition. She's as smart, and in fact, her brain is much more efficient now. We could go forward with these discussion points if anyone is interested. Thank you.
Thank you so much, Sharvaree. So over to you, Dr. Ragini.
Thank you, Meg, and all SIMSOGians for this invitation. I'm so happy to know that you youngsters are really want to discuss menopause. It is something, and you have your own organization also. Wow, congratulations! That I will talk to you afterwards about this organization. And very nice presentation by Dr. Chavan. And specifically, it's the topic, Dr. Sharvaree. I want to ask you how you have chosen this topic, this particular presentation or research paper. What's your in mind?
Ma'am, so this might seem not very professional, but I was scrolling through my Instagram and I saw this certain reel from Grey's Anatomy in which Meredith Grey is in like a room full of people, room full of men, to be honest, and she is arguing why they keep using male mice for studying Alzheimer's and why not female mice. And the men over there, they were like, because you have to consider the menstrual cycle. So
Yeah.
I wanted something related to Alzheimer's and something which would show that, like, in spite of the menstrual cycle, whether it's there or after it gets over, a woman is still that capable.
Okay. So good. You have given me insight. I also make an Instagram and see what is happening in the Instagram group. Okay. So friends, I just want to comment two things here. Then it is open to all to what you want to ask me. Although I think you are very smart. All of you are very smart. I'm a little scared. So the only one thing that this particular research paper which you have presented, I think it should be discussed in detail And your this particular point that women are still smart when they are menopausal. This is my debate always. Why we talk about the diseases after the menopause? Why we talk about the depression? Why we talk about the empty nest? What happened? Yaar? Nothing. It's your time. When the second phase has started after menopause, you are young girls, or maybe some boys are also there. The light does not stop there, it starts. And this particular discussion has proven it. M- We think we have become old, but our brain is not ready to become old. So this is my only one message. When you meet to any woman and she's crying, I have got a menopause, maybe your mother, your aunt or anyone, okay, come on. This is the time when you have to live your life for yourself. Go and live your life. Whatever you want to do in your life, now do it. It is your second era. And I'm forgetting that line. There was a picture, na? Ja Simran ji le apni zindagi. So I think this is the time for a woman to live her own life. So open to you all, whatever you want to ask. For me also, this type of group is a first timer. Anyone?
Ma'am, while we wait for the questions, so I have some questions that some students sent.
Yes.
What are some research gaps around menopause that we as medical students can research upon?
If I say in India, it is a very pathetic situation. Menopause still is not being discussed much. It is more discussed in the non-medical situation. Still in our medical fraternity, in OB-GYN also, people are really awakening that longevity has come up like anything, and a woman is going to have 30 years beyond the uh, her menopause, and she has to live. And especially in the era when there's no joint families, no kids, you have to support yourself. And why you want to all the time shed a tear for the emptiness syndrome? I don't understand this thing. So first you should start with a small survey with the gynecologist, renowned gynecologist, what they understand menopause, what is their view for the menopause. And sometime what I found, the doctors who are not the part of the Indian Menopause Society, many of them don't really understand properly menopause. And second thing which is coming up in a very big way, that the most of the disease when you have in a pregnancy, they are an alert that you are the person going to have a more problem in the menopause. Like a person who is having a PIH, GDM, they are having more of the cardiac event in the later in the life. So one research you can do in this way, the women who are having a more of the cardiac event in the later life, are those women have more of the GDM and the PIH? And literally do one survey first in among the gynecologists and understand. And how much you understand the MST, menopause hormone therapy, not the, we don't call it anymore, is HRT. Your other people are allowed to speak or not?
Yes, ma'am, they're allowed to speak. I've asked them to ask questions. Everyone is feel free to ask questions.
Okay, okay.
Ma'am, meanwhile, I think I can ask more questions.
Okay.
So, even my own mother, she is under, like, she's in perimenopause phase right now, and she has absolutely no idea of what menopause is, of whether she should be consulting gynecologist if she has recurrent periods. So how, as young doctors or as medical students, can we help in spreading the awareness on menopause?
So very nice question. Whenever a woman, today's young woman, aware woman, thought of planning a pregnancy, not all, but the 50% of them go to the doctor as a preconceptional counseling. And then very judiciously whole 9 months they go to doctor for the clinical care to understand what is happening in the pregnancy. And so it is only for the 9 months. And here it is your whole life is at stake. And somehow the menopause care does not start after menopause. This message I want to give you all as a youngster. When a person attain menopause, then it is a phase of only maintenance. And when she crossed the 65, it is a phase of restoration. Before that, between the 40 to 50, it is a period of prevention. And before 40, you are putting the money in your bank. Means we all know about the osteoporosis. So at the younger age, only till 25, you can make your bones. So if you have not focused making your bones solid till 25, so you are not going to have a very good bones. So for as any woman reaching to perimenopause, say 47, 48, whether she has any symptom or not, she should visit to a doctor, because it is a time when there's lots of hormonal changes in the body, and it is a time when many cancers can resurface in the body. So if, although we don't have much of the menopausal clinic, I have really stressing lots in my members that we all should have a menopausal clinic, but it is not a clinic which gives lots of money or patient come for that. The people are not having, but the time is coming when we will have a menopausal clinic. So as far as one thing, tell your mother, go for a general checkup to a gynecologist who is little aware, have a interest in the menopause. Don't go to an IVF specialist.
Yes,
That
ma'am.
is a very necessary thing. Then I will give you a certain basic test which every woman should have. That every woman after 30 years should have a breast ultrasound, because breast cancer is increasing. Mammography after 40, but if there's no family history, ultrasound is normal, you are not required to have a mammography every year. Pap smear, that is must. Specifically to all girls, if you are sexually active, and specifically after 35 years, with co-testing with the HPV is very necessary. Then next thing comes the whole abdomen ultrasound with TVS, because ovarian cancer has no other screening test, no marker. Many times you have just a vague symptom like gas, and basically it is a peritoneal disease. Then general thyroid. Uh, Today, many women who have a premature ovarian insufficiency or early menopause, many times they have a subclinical hypothyroidism also. So thyroid, sugar, anemia correction, these are few tests which should be done. I will not give a long list. फिर तो लोग परेशान हो जाते हैं ना. So this particular few tests every woman should have. How many of you go and ask your mother they ever had a pap smear and the breast ultrasound or mammography? If not, the Mother's Day gift.
That was very insightful, ma'am.
One thing I forgot, which is tell that frequent bleeding, it may be a transitional thing, but she has to rule out by the one ultrasound if she is not suffering some polyp or anything.
Yes, ma'am. Ma'am, what according to you would be the main challenges in designing a longitudinal study on menopause?
Uh, in India,
Yes, ma'am.
because mainly we are not doing any study much. Whenever we present also, we have always a data of some Western country. Last 30 years of my in various association, every time when we talk, we say we should have our data, we should have our data. and we should present our data, but it rarely happens. Maybe too many patients, lack of funds, and we are not trained. That's why I'm so happy you people are being research minded at this age. Maybe your generation will come up with something. In our generation, we are not trained even to do any research or anything. It is only in the medical colleges, in a big medical colleges, people do these longitudinal studies.
Ma'am, from an OB-GYN perspective, how well do these brain changes which are described in this paper align with what we know about the systemic effects of estrogen decline during menopause?
You know, we are talking about long time, say 5 6 years, not very long also. Why this mood and anxiety and depression is more in the 45 50-year-old woman, not in the elderly woman of 60 65? And this was always something why it is happening. And we all know that all those hot flashes, they are a type of the neurotransition. It is not only reproductive transition. And woman whole body, top to bottom, has a estrogen receptor. And when estrogen declines, those it affects everything, starting to brain, to gut, to your reproductive organ, and mostly your sexual need and the vagina, which we don't talk, never talk about that. Women suffer silently with this nocturia because of the uroepithelium is also degenerated with the time, and she has to go urine many a time in the night. She's not able to sleep. It also add in the neurotransition, sleep disturbances. So everything is linked basically. And for that, for everything, you don't need a estrogen therapy. If you know uh, you are suffering from what, many a time a general neurotransmitter like thing, gabapentin, calcium, vitamin, and change in your diet, which is very important, can help you a lot. And what I do in my practice and what I advise to my friends, to this is the time when you are alone. You are too lieutenant. Estrogen, progesterone has left you, and you are stranded on an island alone. So you have only two ways: either you die or you survive. So we ourselves have to think that we have to survive, and the same thing we have to tell our patient. And second thing which I really want to tell you all, if you're going to become a OB-GYN specialist, please respect uterus and ovary. Do not do the hysterectomy unnecessary. And if you're doing hysterectomy, don't take out ovary. Even a woman is a 60-year-old, 62-year-old, because that ovary, that small ovary, a very, very small chilgoja-like ovary, produces the androgen, which gives a little bit stability, little bit libido, and a sense of life to you. So if one thing message can give you, go and talk to your mothers, detail, and whatever, go for their test if they have not done it. Take them to the doctors who are interested in menopause, and you yourself, when become a doctor, respect the ovary and the uterus.
Thank you so much, ma'am. So, ma'am, we have a few questions in the chat box. Ma'am, how can we do research related to pharmacological interventions in menopause?
Research, so that then you have to contact some doctor who has a good practice, and at least for any good research you need at least a 100 patients. So you have to divide in the groups who are taking a pharmacological methods, who are not taking a pharmacological method, non-pharmacological method. Still in our country, acceptance of HRT is very less. Even as far as, if I say, non-pharmacological method, non-hormonal pharmacological method, still people are hesitant, but few people are coming. So only for the research purpose, either you go the first small survey, monkey survey among the population, how many people are having this problem, number one. And if you are having a problem, did you visit some gynecologist, yes or no? And if you have uh, taking some treatment, what treatment you are taking, hormones, non-pharmacological, non-hormonal pharmacological, alternative method, or some yoga and meditation. So you can survey a big chunk of the women, and if you get an answer with the 300, 400 women, you take out your data statistically how many women are really taking some awareness, number one. And if they are aware, uh, really they are taking some medication or not. That is the first step, and very easy step which you people can do very easily.
Ma'am, what are some key unanswered questions regarding the safety and timing of the hormone replacement therapy?
As far as the hormonal therapy is concerned, when you evaluated a patient and you have started, first 10 years of the menopause, post-menopause 10 years, outer limit is 60 years till today, but it is still debatable. If a person is absolutely normal, taking, there's no problem, regularly coming, why not? You can give up to 65, 70 also, but at guideline says 60 years. And after that, if anybody is continuing, you have to tell them that regular checkup is very necessary. And if you are taking it, it's is not in the guideline still. But I know at least 50 doctors who are on Thiruvallur at the age of 70, 72 also. So guideline is 10 years post-menopause and 60 years of the age.
Ma'am, there's also a question in the chat box. Does the Indian Menopause Society have any avenues for undergraduate participation?
Uh, Not till now, but you have given me a food of thought. I will discuss with my president, and if it is not there, I promise it maybe in a 2 or 3 years I am going to become the president. I will certainly make a Yuva menopause wing.
We
You
are
people
very
are the
excited for
future.
that, ma'am.
Yeah, you people are our future, and you are thinking more about this problem than us.
Ma'am, so another question someone has asked is, what are the emotional and psychological changes associated with menopause, and how can it affect a woman in day-to-day life?
So the when we see these emotional things, there are many perspectives. It's not only about the when there's a lots of hormonal changes around 40, 50. So it makes a person labile, as I told you, she's alone. Suddenly the loss of hormone, it affects her part of hippocampus also, amyloid-beta also in the brain, which is the main center for the emotional upheaval. But second thing which we never discuss and never think is the relationship issues. Her personal problems. At many a time, this is the time when she is facing the problem with the teenage kids also. They are not ready to understand that she's going under the problem. At the job also, she's having a problem with the boss and colleagues because she's all the time irritable, emotional. So it will also add. Until unless there's a awareness about this and we don't use the psychologist, we as a OB-GYN specialist, we think that we know everything, even as a medical student also. So we have to think it is not only our MBBS or the allopathy, which is everything about. Because what the physiotherapy can give you when you have a musculoskeletal problems, a orthopedician cannot advise. Like that, when you have so much of the emotional problem, a clinical psychologist visit is also very necessary. When these patient comes to me, you have to sit and listen and listen and listen to them. And 80% time, specifically in the metros, you come to conclusion that it is some and other type of the relationship issues which is literally pushing that woman in that state. This might be a very good research also.
So Mehak has raised hand. She wants to ask a question.
Ma'am, I want to ask that what are the biggest barriers to menopause awareness and care in rural versus in urban India?
Please come again.
What are the biggest barriers to menopause awareness and care in rural versus urban India?
Actually, in the rural area, it is a big taboo to talk about the menopause. And according to them, we are aged now. हमारी age हो गई है. ये तो problems आने ही आने हैं. They don't even understand that every problem menopause is not a जैसे as you presented, that a chronological problem. Aging is something different. Even the WHO definition, it is start from the 65 years of the age. So rural population is a literacy, availability of the money, then their own position in the household. That is also a very important thing because nobody think about them. भी उन्हें भी कोई प्रॉब्लम हो सकती है या ये होता है तो दादी नानी हो गया हो तो ये तो प्रॉब्लम होनी होती है. This is a very, very big challenge. Even in urban area, if you think, there's a handful of people who understand the menopause, mostly the women who are educated and who are independent, or they have money, they are reading. Mostly they don't understand menopause much. That's why this is the big thing after IVF in the field. Everybody is now discussing, from the businessman to all those platforms, and everybody is coming for the menopause.
Ma'am, we have another question in the chat box. What are the risk factors associated with menopausal hormonal therapy, and how do we manage the risks and benefits?
You should not think that MST is an elixir of youth, number one. When you keep it in your mind, you're not going to write MST right and left. Any normal woman coming to you, she needs a lifestyle modification, exercise, diet, mental relaxation, maybe meditation, yoga, and developing a hobby. That is the most important thing, and not dependent on anyone for her own happiness. MST, when it is required, it is your duty to give that woman. Then you have to evaluate her properly. Start with the lowest dose. Ask her to come after 3 months. Again evaluate. If everything is normal, increase gradually. And see what is her problem actually. Then you can withdraw after 6 months. And the second thing, there's a lots of problem. If patient is having a dyslipidemia, patient is having a diabetes, she's obese, but she requires MST. Whether you give or not, it's a very big question. Yes, you can give. You go for the transdermal route. You will not give a oral route. So another factor which comes in the mode of delivery. And then type of the estrogen and progesterone, what you're giving. What we used to give 10 years back, we are not giving today. We are going to the more toward the natural component like 17-beta estradiol. And when I talk about the progesterone, it is the dydrogesterone and the micronized progesterone. What happened in the WHI study, which has put a big black mark on the MST? It was a wrong study. Average age was 62 years. Okay. तो 62 years, हमने तो बोला 60 के बाद देना ही नहीं है. And then they have given this, what the progesterone they have used? They have used metroxyacetate progesterone. And it was found in the long term that MPA causes breast cancer. So The wing which has taken only estrogen, they have less breast cancer than the women who have taken E plus P. So these few things are very important. कि पेशेंट का स्टेटस क्या है, वेट क्या है, उसकी कोमॉर्बिडिटीज क्या हैं. Accordingly, you will devise your MST delivery, and the compliance is the most important thing.
Ma'am, another question is, if there are patients on estrogen inhibitors and are hysterectomized, what can be done to manage symptoms of menopause, especially with regards to musculoskeletal and psychological problems?
She is having only hysterectomy or ovarian removal also.
Only hysterectomy.
So if she has only hysterectomy, and most of the women, if they are convinced that they need a hysterectomy, they are not focused that their whole femininity is finished with the removal of the uterus. Most women have no problem. But we have to advise them regularly between the calcium, exercise, regular exercise, which we give to all women, because ovary is there, it is producing the hormones. So that's why we never jump up for the hysterectomy early, more than 46, 47 years, because the natural age of the menopause in the Indian woman is around 47 years. And any ovary, when you do the hysterectomy, yes, its vascularity is affected. So she can have in the down the line of 5 years, she can develop all the hormonal issues, deficiency issues. When she has, we have to support her. But if because of some reason, maybe endometriosis or maybe other reason, you have removed both ovary and uterus, then you have to support her at the age till age of the 50 with the hormones. Specifically, if your patient is having endometriosis, you can't give a ENP, then you support her with the Tibolon and ask her for a regular visit. That is must. If you put someone on the MST, she has to come for a regular visit.
Ma'am, someone has asked how we as children can help our mothers tackle the emotional issues and other changes of menopause.
As a children, when you understand these problems in the mother is because of the hormones, you have to become more, what I can say, you can help them in many ways, not to be reactive to her emotional outburst. Do a small thing for her. See in what thing she is so happy. Support from you is the biggest thing for the mother. Many times she doesn't want to cook for you, so you cook for her. Maybe not a big meal, just a sandwich. She will be very happy. And it is what a time. It is a 2 or 3 years. She will go in from the transition, and from your lovely paper, she'll become more Superman after that.
Thank you, ma'am. Ma'am, another question is, the paper mentions that not all women experience the same degree of brain changes during menopause. So, what
Yes.
factors like genetics, stress, or reproductive history seem to explain why some women are more affected than others?
Still people don't know. But what I can tell you in my own practice, seeing the woman who are independent, who has own her hobbies and their own group of the friends, and they do something for the society, and they're happy from inside, they have less menopausal problems. And the women who sit at home feel neglected and no support of any kind and lots of time to think, they have these problems more than the women who are busy. But there's no research of this kind of there.
Ma'am, what is the most neglected change in menopausal women, and how is the awareness of therapies other than menopausal hormonal therapy? Uh, sorry. So, what change is most neglected in menopausal women, and how aware do you think women are about therapies other than the hormone therapy?
So if you ask me this question, it's a very good question which you have asked, because nobody think about these women. They can also need a sex. They also need some type of intimacy. They're not just a old woman. When estrogen goes, most of them suffer with the low libido. And at that time, if they have a neglect from the partner, unnecessary marital that thing is also started. And then with the estrogen deficiency, there's a changes in the vagina. And that vaginal itching, burning, even a urine infection like problem, they are treated by the UTI. And what they need? They need the treatment for the local estrogen in the vagina, which not only regenerate the vaginal epithelium, it also regenerate the uroepithelium also, because embryologically urogenital epithelium, you all know that it grows from the same cell. Number two, we have now many therapies for them. We have energy-based devices. The patient is refractory to the estrogen. Regenerative medicine has come in a big way, big way. So we go with the lasers, radio frequencies, PRP, even stem cell therapy is also coming. Although I have not done the stem cell therapy, rest I am doing. Then there's a HIFM chair. That chair, what does it does? It is a basically a pelvic exerciser. And when you sit on that chair, it gives a almost 12,000 contractions like Kegel exercise. So the blood circulation in your pelvic floor muscle increases. So it's like a pelvic floor muscle therapy. It gives a help in your dragging pelvic floor also in the menopausal woman. And otherwise, when there is a lots of blood circulation, it leads to a more um, regeneration in the uroepithelium and the vaginal epithelium. So the most important thing for the woman to discuss this vaginal problem, or what we call is a genitourinary syndrome of menopause, because they don't know. The treatment is aware and they suffer silently. These are their unspoken problems. So you are my
Yes, ma'am. So the next question is, how important is the timing of menopause, like early menopause, late menopause, or even surgical menopause, in predicting brain aging trajectories?
So when a patient has a surgical menopause, specifically removal of the ovary, she has no time for the adaptation. So all symptoms of the menopause appear more, and she has a more difficult time for that. And the same happen when she has a menopause before 40, which is called a premature ovarian insufficiency. And she has to long way go to the up to 50 years without uh, hormones which a normal woman otherwise have. It is going to affect her brain, everything, because she has a longer period without the estrogen, in a estrogen deficiency. So those are the candidates should be put on the MST. 120% they require. If you are not giving them MST, you are doing a wrong. You are really doing a negligence. Then the premenopause between 40 to 45, which we call the early menopause. So this early menopause is a period when you have to evaluate whether she require, if she has some problem, you have to put her on the MST. But every woman should be discussed for the removal of the ovary, and do not remove the ovary until unless it is a really necessary.
Thank you so much, ma'am. I think we do not have any more questions right now.
Thank you so
So,
much.
we sincerely thank you for taking out your time to moderate today's session and guiding this discussion. And we absolutely loved your valuable insights. I hope we all can take back something from this and put in more energy towards research in menopause, which I think is very much needed. We also would like to thank our presenter for an excellent and well-researched presentation. And I also request everyone to fill the post-event questionnaire given in the chat box before leaving in order to receive the certificates.
And thank you so much, SIMSOGians. It's an eye-opener to me also. And I promise, when I will come as a president, I will literally have a EVA wing with all of you. Thank you so much.
Thank
Bye-bye.
you so much, ma'am. Thank you very
Have a
much.
bright future ahead. Thank you.
Thank you very much, ma'am.
Bye. Good night.
Good night, everyone.